Ladies and gentlemen, why don't we get started? Welcome to the Woodrow Wilson Center. My name's Jeff DeBelco. I have the very good fortune of directing our environmental change and security program and coordinating our global health initiative on behalf of my colleagues here at the center and our president and director, former Congresswoman Jane Harman. It's a great pleasure to welcome you all here for a discussion that we've entitled Putting Adolescent Mothers on the Development Agenda. One that falls really on kind of two areas or two tracks and projects that we are working on. We have the good fortune of longtime support from USAID's Office of Population and Reproductive Health under what we call a HELPS project, which is Health, Environment, Livelihoods, Population, and Security. So it's a little bit of everything. So we're very pleased to have their support in doing this. And then we also, under our Global Health Initiative, have for the last couple of years have had an Advancing Maternal Health series. And so we will kind of cross between those projects because these themes are so critical to so many tracks, frankly. And so it's terrific that we're able to highlight and bring them up and have a discussion with a distinguished panel and a distinguished audience. I will say up front, you see two people rather than three. Unfortunately, Sadia Chowdhury from the World Bank had a death in the family, and last night let us know that she wouldn't be able to be with us. Jennifer Redner's kindly agreed to integrate some of the themes around multi-sectoral approaches for adolescent health, putting it on the development agenda. And then Jennifer and Kaylin and Sandeep assured me that there are lots of folks in the audience who could give that presentation as well. So we will rely on you, the expert audience, to make sure that those approaches and those ideas are part of our robust discussion period, which we will have after both of our presenters have an opportunity to present. Leila Hassini is working on a range of women's rights and health issues for many decades. She's IPAS's Director of Community Engagement and Mobilization and Youth Leadership, and she's going to kick us off. I hope you had a chance to pick up the sheets outside with the full bios to see the breadth and depth of the experience that she brings to this discussion. Jennifer Redner works as a U.S. policy consultant at the International Women's Health Coalition and a variety of other capacities and connections and initiatives that bring these issues together in a variety of formats with a lot of the key players in this community. And she will, as I said, now instead of going second, she'll bat cleanup and bring some of these issues together. We have a short batting order, but a powerful one. Just a final procedural note, we're webcasting it, so really all that means for us here in the room is when it comes to the discussion, we'll bring you a microphone so you can pose your question and comment in the microphone so the folks online can hear. For those of you who are watching online, you can go on the website and pull off the PowerPoints in PDF so it would make it easier to follow along than trying to see the screen behind the speakers. So with that, I'll turn it over to Leila for the floor is yours. Thank you very much.
Thank you. Okay, let me just pull this. Oops. Okay. Good morning, everyone. I'd like to just begin by thanking the organizers for inviting me to be here today. Thanks to Emily, to Kaylin, to Jeff. It's also an honor to be here with Jennifer. And just to share a little bit what we're doing at IPAS to build youth leadership for comprehensive sexual and reproductive rights services and to ensure that girls and women have the knowledge, skills, and resources to make autonomous and safe sexual and reproductive health decisions globally. So let me just begin with who we are, and I'll begin with what we believe. So at IPAS, we believe that every woman, including adolescents and youth, have the right to the highest sustainable standard of health and to safe reproductive health choices, including safe abortion care. We're a global organization dedicated to promoting women's sexual and reproductive rights and ending preventable deaths and disabilities from unsafe abortions. We were created in 1973, and we've always had a focus on broadly sexual and reproductive rights with a focus on unsafe abortions. We work holistically, so we do systems level work with health systems to ensure that they are providing women with women-centered, quality, affordable, safe abortion care. We work on laws and policies, and we're fortunate to have Jilmina here, who does our U.S. policy work, but we also work on policies globally. We work on community access, so working at the community level to ensure that women have knowledge, skills, ability, and that we identify barriers that are preventing them from accessing safe abortion services. So we really look at safe abortion from a 360-degree perspective. We have offices in 14 countries around the world, in Latin America, Africa, and Asia. Our country programs are run by local nationals, locals from those countries, and they are addressing the issues in their particular context. So increasingly, we've been developing very deliberate strategies to make sure that we are addressing the needs and realities of adolescents and young women. And this is increasingly important, as you all know. We have currently the largest cohort of individuals between the ages of 10 and 24 in the world's history. We have about 1.7 billion in that age category, and there's another, I think, around billion under 10 years old. So it's really a cohort of individuals with certain realities, with certain needs, and with certain assets, and a lot of creative thinking that they're bringing to the work that they do. So today what I'd like to do is just begin with an overview of the situation of young women in terms of sexual and reproductive rights and abortion, and then give some examples of the efforts that we're supporting at IPAS to increase women's access. So just quickly, these are statistics that you may be familiar with, but I think that they do bear repeating and repeating again and again, because they really are just unacceptable in the 21st century. Every year, 358,000 women die in pregnancy or in childbirth or 42 days after pregnancy termination. That's the definition of maternal deaths. Of these 358,000 women, 25% are adolescents, so they're under the age of 19. In developing countries, except for Eastern Asia, maternal mortality is the leading cause of death among young women. And if you look at the risk of dying from pregnancy-related causes, it's twice as high for girls and women aged between 15 and 19, and 5 times as high for girls ages 10 to 14 as they are for women in their 20s. Excuse me. So in terms of unintended pregnancies, every year there's 87 million unintended pregnancies. So this is 41% of all pregnancies are unintended. And this is really a figure that we need to unpack and understand, because so much contributes to that. It's about unmet need for contraception. It's about sexual violence. It's about contraception being unaffordable, as we're very familiar with in the United States. So there's a lot of reasons that go into this. And 33 million of these unintended pregnancies are to women who are using contraceptive methods. So that's also looking at the fact that contraceptive methods fail, and that there's also user fail rates that contribute to that as well. Every year there are 46 million abortions. Half of these, 21.6 million, are unsafe. The vast majority of these unsafe abortions are in the global south. They're in developing countries. And 30 to 60% of adolescent pregnancies end in abortion. So I'm sorry, I don't want to just bombard you with statistics, but I think it's worth mentioning. This is kind of the lay of the land in terms of what women and young girls are facing in terms of their reproductive and sexual health and rights. And it's very important for us to remember this reality when we think about the programs and activities that we want to support. So this comes from the Center for Reproductive Rights. It's an interactive map looking at abortion laws globally. So 40% of the world's women live in countries where abortions are available, what we say, on request, even though there's always, as we know, different limitations and restrictions to abortion. Another 26 live in countries where abortion is only available to save a woman's life or is prohibited altogether. And if those of you who follow the abortion debates know that abortions are totally prohibited in certain countries like Nicaragua, El Salvador, Chile, Dominican Republic, Malta, and the Vatican City. And we've seen numerous restrictions that are happening in current years in the United States, our own country, as well as in Russia, Mexican states outside of Mexico City, etc. Now, on a positive note, and certainly in terms of adolescents and young women's access, there have been law changes in recent years in two countries that really merit highlighting because they've included adolescents and young women's rights. So one is Ethiopia, where the law was reformed in 2004, and they've included minority as a legal indication for abortion. So if you're under the age of 18, you can use this indication for minorities' access to obtain abortions. And then in South Africa, we have the Choice of Termination of Pregnancy Act, which was implemented in 1997, which recognizes women's right to abortion. And then that is used together with the Child's Act that was implemented in 2005, inspired by the Convention on the Rights of the Child, that addresses several facets of child's rights related to medical decision making. So if this is interpreted liberally, once a woman is pregnant, she is legally emancipated. So she can then make a decision to either carry that pregnancy to term or to terminate that pregnancy. So these are examples of laws that are used to support the rights of adolescents and young women to safe abortions. Now, if we look globally at the impact of these restricted laws, as I mentioned earlier, there's 21 million unsafe abortions every year. 2.5 million of these are to adolescents. And out of this number, 47,000 women die. Now, out of the number of 47, close to half, 46%, are to young women. And if you look at this map, it shows the percentage of all abortion-related deaths that are to young women. And so you see in countries, certainly in sub-Saharan Africa primarily, these rates can be very high, up to 72% in some countries of all abortions deaths that are to young women. So how do we define youth? We know that youth it's a very heterogeneous group that's in constant evolution. The experience of being young varies enormously across regions and countries. Youth come from very different backgrounds. So when we're thinking of interventions, for example, at IPAS, we have to think, well, what are different subgroups of youth? How do they differ across gender? How do they differ across marital status? 1 in 6 girls between the ages of 15 and 19 are married. So their reproductive health needs are different than those individuals who aren't married. There's also great differences in terms of youth who are in school and out of school, youth who are working or not, who live at home or not, great diversity across socioeconomic status, and many other things. But that's just to recognize the fact that we really need to unpack this category of youth and look at it from a heterogeneous perspective and then develop interventions and activities accordingly. We also think about young people across different stages of life. So we use the UN definition, which refers to 10 to 19 are adolescents, 15 to 24 are youth, and then the package of that is 10 to 24 are young people. So really looking then at the very different needs. If you're pregnant and a 10-year-old, your needs are quite different than if you're 22. So how do we address those realities and different needs? And to really focus on that when we're thinking about different activities. So while recognizing these differences, the research that we've done at IPASS has highlighted some barriers that play out differently in various contexts, but just ones that I want to address. So one that I'm sure you're familiar with are just gender roles and stigma around youth sexuality. In general, girls do face greater socioeconomic barriers to accessing sexual and reproductive health services than men, and there's a great deal of social disapproval of girls' sexuality outside of marriage. We also know that there's very high levels of sexual harassment and gender-based violence that girls face globally. Child marriage is very common in many of the countries we work with. In Ethiopia, where we have a vibrant program, 46% of girls under the age of 15 are married. So how do we address that in our sexual and reproductive health programs? In terms of abortion, generally speaking, there's an overall lack of knowledge of what abortion laws say and how can they be interpreted to the full extent of the law, in where women can go to get services, and what different abortion technologies exist that women can use. We also have lack of youth-friendly services, services that really include youth in the way that they're developed and set up and offered, that really respect the needs of privacy and confidentiality, that are affordable, where language and is communicated in a way that's accessible and understood. That's a real challenge for adolescents and young women. And then we know that there's a lot of challenges just around from the perspective of health providers and their understanding of the needs of adolescents and young women and how best to communicate with them. So how do we do our work at IPASS? As I mentioned earlier, we work on these issues comprehensively. We work both at the community level, the health systems, and the policy level. And we really believe both in doing that systemic work as well as the work around social norms and social change, and then the bigger policy and advocacy work. And while I've highlighted in these presentations just previously a lot of the statistics that are somewhat overwhelming and some of the barriers, we also really want to look at young women and youth as having real assets and bringing a lot of knowledge, strengths, creativity, and different ways of accessing information and sharing it that we can build on. So let me give you a few examples of what we do. So I'm going to begin with just some of our advocacy work and our efforts in Malawi and Zambia. So Malawi has one of the world's strictest abortion laws. Abortion is only allowed to save a woman's life. So we are working there with a coalition of youth organizations and youth leaders to raise awareness of the impact of unsafe abortion on women, on young women and adolescents, and to advocate for comprehensive sexual and reproductive rights, including law reform in that country. And this group is coupling the legal and policy work that they're doing with practical information that they're providing youth through a helpline. So they have a helpline that's set up that youth can call into to get information on sexual and reproductive rights, including abortion. In Zambia, we're working with the Youth Advocacy and Action Team, and this is a consortium of young people who have come together, including different civil society organizations and educators and coming from different institutions. Zambia has a law that's fairly liberal. They overturned their colonial law, the British law, in 1972 and developed their own legal system. There are a lot of medical barriers in that country to accessing services. So the youth groups are looking at how they can advocate to overturn the barriers that exist in that country while simultaneously sharing information on where youth can get services. Services are in place in certain places in that country, and also just discussing different abortion technologies and needs so that people know about the rights that they have. In Nepal, the abortion law was changed in 2002, and it's now legally permitted up to 12 weeks of pregnancy on request, and then up to 18 weeks in certain cases. And there we're working in the Rupandehi district on an innovative behavioral change model that's working with young women who work in factories. So going really to women's site of work, and this is important, is really knowing where there are locations where we can go that makes it easier for young women to access services, and then doing work around what the abortion law says, what their rights are, and then we're accompanying this with an accompaniment program that will accompany women who need reproductive health and abortion services. And then finally, in Latin America, there are some of the world's most restrictive laws. As I mentioned earlier, some countries prohibit abortion for all reasons. So we're working in 2 countries, Argentina and Ecuador, using a harm reduction model, which basically looks at how we can reduce the harm from unsafe abortions and provide women with the right to information and provide them with information on misoprostol, which is medical abortion, and how they can terminate abortion safely, even in contexts where it's highly restricted. And they're doing this through hotlines and through accompaniment programs with young women. Excuse me. So we also seek to link the efforts that we're supporting locally with regional and global work, and Jennifer's going to speak a lot more about the global work later. But we look at some of the networks that have both local, regional, and global work, such as the Medical Students for Choice. Those are networks that have local chapters, regional chapters across Latin America, Africa, and Asia, and they also work to influence global institutions, global groups like the Federation of OBGYNs, global groups that are working to ensure that governments are held accountable for international consensus agreements like the International Conference on Population and Development. Jennifer will speak about that earlier, as well as countries' human rights agreements and responsibilities. So this is an interesting approach to say what's happening locally, getting groups to also organize on a regional level, and then linking up that to global change efforts. Now, some of the resources that we've developed to support our activities, I want to highlight some of these, and if any of you are interested in them, we can send you copies, or these are also downloadable on our internet. But we've produced the Abortion Care for Young Women, which is a training toolkit for all individuals who work at the health system. So it's not just the providers of abortion services, but it's anybody in the health system, from the individual who first greets women or girls when they come to the health system to the individual who would be providing the service. And it's interesting to note that there were no such manuals that existed specifically on what adolescents and young women need. We've also developed the Young Women in Abortion, a situation assessment guide. And this guide informs our work when we are working in a country, developing an activity or piloting an intervention. We begin by doing a situation assessment, which looks at collecting data on the realities, experience, and needs and assets of young women, looking at where women are already going for information and care, building on existing structures and systems, and identifying partners that we can work with. So this is a tool that we've developed that was piloted in 4 countries with support, by the way, from the World Bank. I'm sorry that Sadia isn't here, to strengthen our efforts in those countries. A couple other resources that I wanted to bring to your attention include Exploring Abortion, a collection of self-reflection and sensitization activities for global audiences. And this builds again on work that we've documented about the needs and realities of adolescents and young women. We have done, we've produced in a document the results of our needs assessment survey in Nepal. And then we've also adapted some of our values clarification activities for young women and adolescents. So really looking at how we can think about the needs and realities of young women and adolescents through values clarification exercise and through exercises that encourage us to think more about their needs and their realities and how we can best meet them. So I want to thank you. I think we'll be taking questions at the end. Is that correct, Jeff? Yeah. Thank you so much.
Hi, good afternoon. It's really a pleasure to be here, and I just wanted to also echo thanks to the Woodrow Wilson Center for hosting this really important discussion, and all of you trekking over here to participate as well, and really look forward to your contributions to the discussion after we've had an opportunity to speak. As Jeff said, my name is Jennifer Redner, and I'm a U.S. policy consultant for the International Women's Health Coalition. For 26 years, with partners from the Global South, IWHC has led and partnered on strategic initiatives to influence policies and funding by global agencies and governments to secure sexual and reproductive rights and health for women and girls. IWHC's work is grounded in the realities of our local partners and of the people that they work with in countries of the Global South. We collaborate with local organizations in over 30 countries across Africa, Asia, and Latin America. So my colleague Layla did an excellent job about making the case of why adolescent girls, and most of us here understand that a girl or woman who doesn't have control over her own body, including whether and when to have sexual relations and to bear children, cannot make decisions about other aspects of her life, such as education and employment. In too many places, the fundamental right of every woman and girl to control her body simply isn't recognized. For a girl, control over her body and her sexual life requires more than access to health services. Her most basic human rights, freedom from violence, discrimination, and coercion, must be protected, both in their own right and to enable her access to services. Far too often, basic rights are not protected. Currently, 1/3 of the world's population is under the age of 19. 9 of every 10 of the world's adolescents live in low and middle income countries where opportunities for schooling, employment, and healthcare remain limited. And these numbers will grow. While we have long invested in children under the age of 5, we are largely unprepared to meet the health and development needs of those ages 6 to 19 years old. Generally, this group tends to be healthier than babies and adults, but nowadays, these young people face many challenges. Challenges that most politicians don't want to address, and health professionals are just beginning to acknowledge as their responsibility. Many of these are connected with sex and sexuality, a subject that many, if not most people in public life try to avoid, no matter what the cost. Yet we see the consequences of inaction, including the fact that pregnancy and childbirth-related complications are the leading cause of death and disability for girls aged 15 to 19 years old in the developing world. As leading Egyptian obstetrician gynecologist Mahmoud Fatala pointed out decades ago in his now landmark classic speech, The Road to Maternal Health, women's life journeys are long and hard. They too often end in death as a result of multiple failures on all levels: familial, clinical, social, and global. Unfortunately, the same can be said about the life journeys of adolescent girls, though we don't talk about it enough, which is why the event such as this one on this particular topic is so important today. But there are opportunities to create change in the lives of adolescent girls today. To create change in the lives of adolescent girls, multiple issues must be addressed. Social conditions that prevent them from going to the health clinic when they need to, poverty that drives the malnutrition that puts both girls and their infants at risk, violence by their husbands or intimate partners that makes them afraid to negotiate condom use and which often increases during the pregnancy, and a failure of governments and donors, as well as the UN system, to prioritize and fund the actions needed. Multi-sectoral programming that works with adolescent girls and their communities to address the multiple barriers that girls face accessing health services, attending school, preventing early marriage, preventing violence, and building the economic assets of girls will contribute towards our collective goals of ensuring that girls can safely transition to adulthood and can be economically productive members of their community. I will now quickly go through 3 opportunities in particular where implementation of actions needed can accelerate progress in the lives of girls. You will notice that the action steps are not necessarily anything new. They're not really groundbreaking, but that's the point. We already know what we need to do. We have the global consensus in terms of what needs to happen, and together we can accelerate progress in the lives of girls today. So I will quickly go through these 3, beginning with the implementation of the ICPD Program of Action, international agreements such as those adopted at the International Conference. There we go. Implementation of the ICPD, International Conference of the Program of Action of the ICPD, which was developed in 1994 and affirms the rights of all adolescents to receive sexual and reproductive health information, education, and services in accordance with their needs. Through foreign policy and foreign assistance, the United States aims to alleviate poverty and promote security and stability around the world. Central to these efforts must be the promotion of the health and rights of all people, with particular attention paid to the needs of adolescent girls. The U.S. should utilize the Global Health Initiative to implement the Program of Action of the ICPD, as well as the Global Strategy and the WHO guidelines, which I will speak about more in a few minutes. In particular, the Women, Girls, and Gender Equality principle of the GHI must be implemented in a way that promotes and protects the human rights of women and girls, including the right to marry with full and informed consent, be free from violence, including sexual violence, and the right to the full range of information and services needed to make healthy and informed decisions. We also need to ensure that access is provided to youth-friendly and confidential comprehensive sexual and reproductive health services, including voluntary contraception and family planning, maternity care to ensure healthy pregnancies and safe childbirth, prevention, testing, and treatment of STIs, including HIV, referrals and linkages to services to prevent mother-to-child transmission and to treatment and care, preventing and responding to violence against girls, including referrals and linkages to legal and social services, safe abortion services and post-abortion care, and medically accurate, comprehensive sexuality education that includes information and skills to delay sexual relations, have healthy sexual relations, and promote respect for individuals' rights and autonomy. There's a reason that I just went through this laundry list, if you will, of these services, because all of them are so closely related. Hence, we need to be providing these as a package of services. In addition to these services, they should be linked to broader health and development programs through multi-sectoral approaches with the health and human rights of girls at its core. For the Global Strategy for Women's and Children's Health, the Global Strategy sets out a path of how the U.S. can work with others to help women, including adolescent girls and their children, to realize their right to the highest attainable standard of health. The document was developed under the auspices of the UN Secretary General Ban Ki-moon with support and facilitation by the Partnership for Maternal, Newborn, and Child Health. The global strategy was launched in 2010 with approximately $40 billion US pledged toward women's and children's health and the development and the achievement of the MDGs 4 and 5, which are to reduce child mortality, improve maternal health, and achieve universal access to reproductive health services. In the world's 49 poorest countries, where the need for external assistance is greatest, progress between 2011 and 2015 will be made through priority action to enhance financing, strengthen policy, and improve integrated service delivery. And they'll do this through support for country-led health plans supported by increased, predictable, and sustainable investment, integrated delivery of health services and life-saving interventions so women and children can access prevention, treatment, and care services when and where they need it, stronger health systems with sufficient skilled health workers at their core, innovative approaches to financing, product development, and the efficient delivery of integrated health services, and improved monitoring and evaluation to ensure the accountability of all actors for results. We also hope that this will help bolster efforts to collect age disaggregated maternal mortality data so we can know more about the impacts of early marriage and the impact of maternal mortality specifically on adolescent girls. The WHO guidelines to preventing early pregnancy and poor reproductive health outcomes among adolescents in developing countries, these guidelines are primarily intended for policymakers, planners, and program managers from governments, non-governmental organizations, and development agencies. They were developed through a systematic review of existing research and input from experts from countries around the world, and in partnership with many key international organizations working to improve adolescents' health, some of which may be in the room right now or listening to the webcast. And welcome. Key recommendations contained within the guidelines and their rationale, and I'll quickly go through those, are ending child marriage, and doing so by, in countries where there are laws that prohibit early marriage before the age of 18, that's fantastic, and they must be enforced. Where there are no laws, laws need to be developed as well. Keeping girls in school, again, getting to the multi-sectoral approach to addressing this issue. Today, fortunately, there are more girls enrolled in school than ever before, and we know the research shows the impact that it has on a whole range of development outcomes, including health as well. And not only their health, but the health of their communities and their families. Also, girls who are in school are much less likely to marry, and increased formal and non-formal educational opportunities for girls at both the primary and secondary level are needed. We need to influence cultural norms that support child marriage. In some parts of the world, girls are expected to marry and have children in their early teens or middle teenage years, well before, as we know, that they're physically or mentally ready to do so. Parents may feel pressure to marry off their daughters based on prevailing norms. And through community-based interventions, we need to work with communities to address these norms around early marriage so that we can challenge them and change them. Secondly, we need to foster understanding and support for early pregnancy prevention. And by supporting pregnancy prevention programs, we have to have a special emphasis on comprehensive sexuality education. We need to reduce coerced sex. We need to formulate and enforce laws that prohibit coerced sex and other forms of violence perpetrated against women and girls. We need to empower girls, and we need to influence the social norms that condone forced sex. We also need to work with men and boys. We need to work with them so we can help them examine the gender norms and behaviors that lead to sexual and other forms of violence perpetrated against women and girls. Next, we need to reduce the incidence of unsafe abortion. To do so, we need to ensure that adolescent girls have access to safe and legal abortion services, as well as to the appropriate post-abortion care, regardless of whether the abortion itself was legal. Adolescent girls must also have access to increased skilled care, prenatal, childbirth, and postnatal care, as well as basic emergency obstetric care and comprehensive emergency obstetric care, according to the guidelines and according to best practices that we're all well aware of. So I just went through several opportunities of actions that we already know need to be taken, and we know that the global consensus exists to take action. And so the question is, in the near term, are there also additional, in addition to action in terms of programs, funding, et cetera, are there opportunities on the near-term horizon where we can increase the visibility of adolescent girl issues on the broader international development arena? So in addition to increased U.S. partnership with other country governments and key stakeholders, including young people, as well as support for implementation of the ICPD, the global strategy, and the WHO guidelines, all done, we hope, through the Global Health Initiative, there are several opportunities before us on the horizon for the United States to continue to demonstrate its leadership and support for the health and rights of adolescent girls, regardless of whether or not they are mothers. The first opportunity that I wanted to put forth is the World Health Organization's Executive Board meeting taking place at the end of this month. We do hope that the U.S. will work to secure strong action by the Executive Board in support of addressing early marriage and adolescent pregnancy. During the upcoming United Nations Commission on Population Development, which will be happening in April, there will be a document negotiated on adolescents and youth, and a strong outcome document is needed. Strong U.S. leadership in support of a strong outcome document and young people's health and rights will be needed to achieve this document, and we do hope we can count on their support. Also, the upcoming G8 in May. This is a prime opportunity to demonstrate U.S. leadership with other G8 members and the international community to implement the global consensus that exists, and which I quickly went through pieces of today, on how to address the health and rights of adolescent girls through increased political and financial commitment. And as Congress continues to debate budget cuts, we need to continue to make the case of why the U.S. foreign assistance budget must be sustained. It is about 1%. 1%, and the global health budget is a fraction of that, though many of the American public believe it's 25% or more of the total national budget. That small portion of our budget makes a huge difference to the women and girls that I discussed today. Specifically, the foreign assistance budget for the administration's Global Health Initiative. It leverages more funds from other donors, and not only donors, but from recipient countries. It generates goodwill and good neighbors in our increasingly globalized world. A minimum package of health services in the world's 49 poorest countries cost $44 per person per year. In the United States, U.S. health spending was nearly $8,000 per person per year in 2009. Health investments in poor countries is a bargain with high returns. Investing in young people with a particular focus on adolescent girls is essential to make lasting change in how men, families, and societies value girls and women. If these younger generations learn to treat each other on the basis of equality and full respect for women and girls' autonomy and human rights, we will eliminate the major factors that drive violence and discrimination among women and girls that make them more vulnerable to unwanted pregnancies, unsafe abortions, and other poor sexual and reproductive health outcomes. At the same time, young people will continue to become a powerful force for social and economic development. When you invest in a young person, you will reap the benefits of investing in 2 generations, young people today and their families and communities of tomorrow. Together, in partnership with governments, multilateral institutions such as UNFPA, civil society, women and youth-led organizations, and young people themselves, we can end child marriage, provide young people with the comprehensive sexual and reproductive health services and comprehensive sexuality education that they need to realize their full potential and our collective goals of gender equality and prosperity for all individuals and nations. Thank you.
Thank you very much, both of you, for both setting a stage with the data-rich presentations and then also suggesting current efforts for ways forward, but also what we're not doing that we could and should. Why don't we open it up for the discussion that we promised? As I mentioned, we'd love for you to use a microphone so the folks online can hear your question as well. My colleagues will bring that to you. So who would like to kick us off in terms of a first question or comment? Okay, maybe Emily down here in the front. And of course, if you could just let us know who you are too, that'd be great.
Hi, I'm Beth Outerson. I'm at Save the Children. I have a very specific question for Layla around post-abortion care. I mean, Save the Children and other organizations have restrictions about what they're allowed to do regarding abortion. You know, it's something that we can't really focus on. It's not part of our mandate, but we can look at post-abortion care. So I was wondering if you could talk a little bit about the differentiation between promoting safe abortion and post-abortion care and how that can be differentiated in terms of programming and policies for organizations that really have to think about that difference.
Mm-hmm. Okay. Do you want to take one question or?
Sure, well, we
Yeah,
can
okay.
have that opportunity.
Okay. Yeah, thank you. Thank you for your question. IPAS works on both post-abortion care and as well as induced abortion. And increasingly, we're also broadening that to include the right to information about medical abortion technologies that a lot of women are using on a regular basis. And we're really seeing the abortion field is really changing because of the presence of medical abortion and the fact that women are increasingly, in many countries, just getting medical abortion pills and misoprostol from pharmacies and drug sellers. And in some countries, there's no interface with the health system. They're just having their abortions on their own. And so we always want to make sure that all those types of abortions are safe. So in terms of post-abortion care, of course, every government, regardless of the legality of abortion, has the responsibility to provide post-abortion care services, emergency obstetric services to women who have had spontaneous abortions or who are going in for post-abortion care. So I think that that's something that is an obligation of every government. That's something that you could work on, and that we work on. We train providers in post-abortion care in countries where abortion is legally restricted, and we do that in all kinds of countries where it's legally restricted and in countries where they're providing both induced impact services. So I think it's something that you could and should include in your efforts, and there's I don't think any reason for you not to do that. That's something that's a basic right that women need, and a healthcare service that they should be entitled to.
Other questions and comments? I have one down here and then one over there.
I have two questions, so maybe I'll ask them both, and then the panelists can respond. One is fairly specific, again, to Layla. You mentioned accompaniment programs, and I was just wondering if you could speak a bit more on the details of that. It's something that I've heard talked about more recently, and I'm not 100% familiar with. I forgot to introduce myself, sorry. My name is Callie Simon with Pathfinder International. And then the second question I'd like to ask is a bit around adolescent mothers. So the title of the session today is on putting adolescent mothers on the development agenda. And while you both spoke very eloquently about adolescents and adolescent girls more broadly, I wondered if maybe both of the panelists could speak more to some of the specific challenges we face with adolescent mothers who, in my experience, have been some of the most neglected from programming. So things like comprehensive sexuality education, even youth-friendly services and peer education focus very much often on girls and boys in school. Adolescent mothers often aren't in school. They also tend to focus very much on preventing the first pregnancy. Adolescent mothers, by definition, have not prevented their first pregnancy. So I wonder if you could speak more towards some specific approaches that we should be considering for this particular population. Thank you.
Thank you. So I'll give you two examples of accompaniment programs. One is in a Latin American country where we work, where abortion is legally restricted. And so this is a group of individuals, of women's health advocates, of medical providers, and they're distributing misoprostol, or they're linking women to places that distribute misoprostol, and they're accompanying women through the abortion experience. So as you know, with a medical abortion, it takes more time than vacuum aspiration. So it's about accompanying them. And then once that process is completed, women who have gone through that, the accompaniment, often serve to help others. And the idea as well is that the way that we think of safety of abortion, it's not just medical or clinical safety, but it's social safety. It's how you can feel positively about your experience, how you don't feel stigmatized, how you can feel supported in the choices that you make and through the process of having an abortion. So that's one example. And then in Nepal, the example that I referred to is, again, there are all kinds of barriers in terms of women knowing where services exist, having what we refer to as procedural knowledge. How do you navigate a health system? There's a power differential there with a woman and a health provider, and certainly with a woman and an OBGYN. So how do you have this knowledge and skills and accompaniment and support to navigate those systems, to work through those systems, to know what questions to ask, how to get quality care, how to get affordable care, if there's costs, that people are asking you to pay if you know how to then negotiate that. It's much more about the accompaniment of getting both to the service delivery site as well as navigating those services. Does that answer your question? And then on adolescent mothers, Jennifer might have more to say about that. But I think you're absolutely right, and I think it gets down to how we think about subgroups within groups and how we then develop strategies, including these women with them, and so that it's not us knowing what they need, but engaging in a community dialogue, in a participatory dialogue, to then understand what makes the most sense for them. And we do know that adolescents who are married often want to even prevent the first birth. That's really, really hard to do because they don't have access to the skills to negotiate safe sex. Marital rape isn't recognized. They don't necessarily have access to contraceptive or want to use the methods that are available to them. So I think it's really figuring out in a particular context through discussions and dialogue with adolescent mothers. And then again, it's looking at where you go to find those groups. Is it at homes? Is it at workplaces? Is it at religious sites? Is it at places where peers come together? Is it through peer networks? Thinking about in a particular context what strategy would be most effective.
Thanks, Callie, for your question. I think the question you're asking is from a more technical, programmatic service delivery standpoint, and I think that Layla covered those pieces really eloquently around the conceptualization of adolescent mothers versus adolescent girls in terms of where I came from my discussion today. Is one could argue that once that girl has that first birth or becomes pregnant, that the system has failed her. The health system, the school system, the community system, et cetera. And so the question becomes, do we only reach that girl once she already is a mother, or do we try to reach her before she becomes a mother? And the question, of course, is both, meaning once we've failed the girl in terms of her early marriage or her early unintended pregnancy, then we need to ensure that she has the access to the information and services for safe delivery to prevent another unintended pregnancy, et cetera. One of the concerns that I have overall conceptually around this is very similar to the concerns we have around other mothers and children initiatives that are out there, in that it puts out that perception that the value of a woman is contained within her reproduction. And we want to make sure that women and girls, regardless of whether or not they choose to have children, and hopefully they're always able to choose to have the child, that they still are valued and that we're still looking to reach them with information and services so that we can avoid the pitfalls that we know too well around early marriage, around violence, around HIV infection. Neither of us touched upon HIV enough within our discussions, and just wanted to make sure that you understand when I speak about sexual and reproductive health, I'm certainly including HIV, which we know is disproportionately impacting young girls today.
Kaylin?
Hi, Kaylin Ostrowski with the Wilson Center. Both, thank you so much for your excellent presentations. And I just wanted to ask and follow up on, you'd both mentioned the importance and involvement of male participation, but I didn't hear either of you talk about the importance of faith-based organizations. And I'm wondering if you have any experience working with faith-based organizations as well as religious leaders. As Jeff had mentioned, I coordinate the maternal health series here at the Wilson Center, and we did have a workshop on faith-based organizations, but we didn't really tailor that at all to youth. So I'm really curious to hear how youth and religious and leaders and institutions can address what we've been talking about.
Sure, I can take that. So again, sort of from a more policy perspective, we have many allies within the faith-based community that are in support of young people's access to comprehensive sexual and reproductive health services, as well as comprehensive sexuality education. While we do have strong partnerships with those organizations, there are those faith-based organizations who have decided for one reason or another that it is morally objectionable to provide women and girls with the full range of information and services, and particularly when you're talking about unmarried girls versus married girls as well. So I think faith-based organizations are strong partners and allies as long as we together can implement international standards and international agreements in terms of best practices and what really needs to be provided to adolescents and women. But certainly faith-based organizations have historically had reach in communities where no other organizations have, and should be a very strong partner in support of the health and rights of young people.
Can I, yeah. Thanks for your question as well. Just to build on what Jennifer said, I think anytime you're doing community work, the issue of faith and religion surfaces. Whether you're a faith-based organization or not, people discuss it, people have ideas about it, people want to also know how you engage with a religious argument or a faith-based argument. It's something that we all have to deal with anytime you're working on these issues in local context, and one that we really need to address openly, and I think be very open and honest and proactive about addressing. We, as Jennifer said, you always work with faith-based organizations. I mean, the reality of the world is that they are organizations that provide a lot of social services, that are present in communities, and I think it's about having those conversations and thinking about the values that people have, and then really trying to have discussions that ensure that people are recognizing the needs and realities of young women. I also, if anyone is interested, I come from Algeria, a majority Muslim country, and have done a lot of work on abortion in Muslim contexts, and have published several publications on looking at the diversity of laws and policies and practices across the Muslim world. You have countries like Tunisia that liberalized its abortion law before the United States. It's covered by the public sector funding and is available in a way that's not as controversial in the U.S. And I think it really helps us to also think about other contexts and the way that religious leaders have supported family planning, sexual and reproductive rights, and how we can build on those efforts and learn from those efforts in different regions. There's also a very interesting global network called Musawa of women theologians and leaders in reproductive health advocates looking at gender equality in Islam and looking at sexual reproductive rights and promoting them within Muslim context. It's based out of Kuala Lumpur, and I can share the link with you, or you can Google it if you so choose. Thanks.
Hi, I'm Kate Lane with USAID. I was just going to give you a very concrete example of having worked with some religious leaders in northern Nigeria, and we wanted them to work with men who were married to young women to help them delay their first pregnancy or space subsequent pregnancies. And one of the things that was very interesting was when we went, one of the things we did with them to do a workshop with them around sort of, the high rates of maternal mortality and morbidity. And we said, okay, the maternal mortality in northern Nigeria is 1,000 per 100,000. We're like, okay, so, to them, if a religious leader hasn't traveled much out of their community, it's just the norm. It's just the reality of what happens in their community. Girls get pregnant, girls die. And it wasn't until we started to say, okay, but listen, in southern Nigeria, the maternal mortality is 400 per 100,000 women. And then they're kind of like, oh, okay. So you sort of set up this paradigm that this is not good compared to the rest of the country. And then also working with them around, you want to be good leaders, you want to protect the health and well-being of your followers. This is one way of doing it. Not necessarily going in and saying, you have to get your followers to use family planning, but as a good leader, this is what you do, is you protect the health, the well-being, and the vulnerable people in your community, which would include these girls who are married and sort of isolated from their community. So just as a concrete example.
I guess this is a good time for me to ask a question. The benefit of manning the mics or womaning the mics. I know we've talked a bit about male participation and also faith-based communities, but I'm wondering if either of you can talk about your experience with programs abroad or hearing about programs abroad that work specifically with mother-in-laws and around son preference, because I think those are tied very distinctly to adolescent motherhood as well.
So I think, especially when it comes to adolescents and young women, the research that we've done so far shows that there are networks of decision makers that they go to, that they refer to. This does include mother-in-laws. It does include men. Men can both be gatekeepers, and they can also facilitate women's choice. And certainly in the case of women accessing misoprostol in pharmacies, we've noted in some countries that it's easier for men to go in and ask for the misoprostol for the grandmother's ulcer than it is for women. So I think it's looking at what are the networks that adolescents and young women use for information, for care, for support, and then how can we build those networks to make sure that they're supporting women and providing safe information to them. So mother-in-laws, I think we don't have deliberate strategies, to answer your question, to work with mother-in-laws, but when we do our assessments, we are assessing who women go to, who are the kinds of social networks and peer networks they go to. We do work at a community level with men, because often they both play the role of gatekeepers and supporters. And so we're looking at where they can help facilitate women's choice, where they can also be held accountable and responsible, because if a woman's pregnant, there's a man involved. And so it really depends on local context and where that makes sense, always realizing that ultimately the decision is up to women and adolescents, girls.
Great. So I'm going to use two different examples. The first one is around engaging men and boys for women's health and rights and adolescent girls' health and rights. So working with men and boys is critically important for transforming gender norms and for sustained change over time and transforming generational transformation. One of the things, though, we want to make sure is that it's not in lieu of working directly with women and girls. And, initial PEPFAR analyses showed that the vast majority, if not the entirety, of the gender-based violence portfolio previously was working directly with men and boys with little to nothing directed towards women and girls. So it's both, and, it needs to be proportional depending on the risks and the need associated with it, but we do want to make sure that it's not used as a proxy or in lieu of. And similarly with, I'll use the example of mother-in-laws in the context of child marriage and child marriage prevention, but also once the girl is already married and most often living in the home of her husband, which includes the mother-in-law, how those dynamics play out. And as Layla aptly described it, we call those the duty bearers. So whether it's the religious leaders, it's the fathers, it's the husbands, the brothers, the mothers, etc., they all have a role to play in working to empower girls and, of course, making them incredibly more vulnerable to violence and all these negative health outcomes. And really, how do you work with them to ensure that girls are seen as assets within the family, are seen as potential economic producers, not just children producers as well, and sort of transforming, again, those norms around the values of girls so that it isn't the sole preference to have a son, and really raising the visibility of the full potential that girls have and with support can have. But the same caveat I just wanted to say about that as well is in early marriage prevention work, and then of course working with married adolescents, it's critically important to work with the duty bearers who can decide whether or not a girl could participate in a program or access a health service. But we want to make sure that it's not in lieu of working with the girls directly and building the assets of the girls directly. So again, it's both, but we need to make sure that girls remain central to any of those programs.
Question at the end of the table right there next to you.
Kara Chrisman, USAID. I think this is a somewhat quick question. When we're looking at programs to deal specifically with adolescent mothers, I caught that 1 in 6 girls are married and that 11% of the births are to adolescents, but how many, when you have these programs, what percentage of the girls are married that are having these births, and what percentage, or maybe not even the numbers, but in terms of, is it a larger issue with the young married women or not? Does that make sense?
Sorry, would you mind repeating that? I didn't. Did you understand it? I'm not sure
I
I
mean,
got
think
it.
the short answer to that is that the vast majority of sexual activity takes place in the context of marriage, particularly in the developing world. I mean, it's the vast majority of sexual activity takes place in the context of marriage. So, you know, in terms of health-seeking behavior, sorry?
For girls.
Right. Yeah.
Yeah, sorry.
But then in terms of health-seeking behavior, whether or not that drops off for unmarried versus married adolescents, did you? No. Oh, okay. Okay. So whether they're able to access the service as unmarried adolescents, I think contains a lot, is very contextualized depending on the service provider. Are they going to discriminate against the girl because she's unmarried? And therefore, are the quality of services high enough so that she may not even seek seek the services to begin with? And then, of course, you have the married adolescent girls who may have extreme pressure to begin bearing children as quickly as possible and in quick succession, and may not be in any way encouraged to seek health services where family planning may be provided to be able to space and determine births. So I think it really depends on the context, but one can remain pretty confident that the vast majority of sexual activity among adolescent girls in developing countries takes place in the context of marriage. I don't know if you want to add anything.
No.
Okay.
That was great.
Did you want to go first? Oh, sorry, I was just in my own world, not paying attention to. I'm Edna Jonas. I'm with MSH, African Strategies for Health Project, new project. Just kind of a follow-on comment to what you were saying. It seems then that the critical issue is more preventing early marriage. And there are some examples of successful efforts to do that in a few countries by a few programs. Like Engender Health was working in Nepal and had some success a lot of success in reducing the rate of early marriage in a certain district area where they were working. That's not to say we can't, that we're going to be able to address that quickly and alleviate all the health issues, and we need to look at these other issues around access to services and awareness of the dangers of early pregnancy, because you're not going to be able to alleviate the issues around the dangers of girls that young becoming pregnant. So seems to me that the priority is really trying to reduce the numbers of girls who are married off at very young ages.
I mean, I think that's very, very important. And I think also gender-based violence and non-consensual sex and transactional sex are increasing in many of the countries we're working with. And that's something that's happening at younger and younger ages, and it's totally outside of marriage. So I think that is one strategy. I think that gender-based violence is huge. It's a pandemic that we need to address. And that's increasing. We're seeing that increase in many of the contexts we're working with, as well as transactional sex, that all of this is integrated. When you lack opportunities, you then get married at an earlier age and there's a lot of, I think the multisectoral approach is really, really important, because it really does bring together what are your opportunities if you're 15 and you don't want to get married in a certain context.
Yeah, and just to add again, I think it's really dependent on the actual country and what the context is and what is the situation facing adolescent girls in that particular country. And even drilling down even further, the national level statistics around age at marriage are not going to give you the accurate picture about what adolescent girls need. And you'll find, so for example, in countries where child marriage is prevalent, and particularly in specific regions where we consider to be hotspots, then of course the issue of child marriage prevention or working with married adolescents needs to be a core piece of any intervention working with adolescent girls. In other countries where child marriage is not as prevalent, we're still seeing incredibly high rates of unintended pregnancy, incredibly high rates of HIV, high rates of unsafe abortions, et cetera. And so, the best advice one could give is to really drill down to the community level and look at what are the actual needs and issues impacting girls in that area, so that programs are not cookie cutter and not designed with one monolithic adolescent girl in mind, but they're not only targeting the most vulnerable adolescent girls within that community, but targeting them with the range of services that will help them, whether it's education, livelihood skills, health services, of course, as a core component of that, and determining what the needs are and basing that program around those needs.
I just had a follow-up comment that I saw recently. I read a report from the World Health Organization that when you compare adolescent mothers who are adolescent girls in Africa who are sexually active, who are married and unmarried, the married adolescent girls who are sexually active actually have higher levels of HIV infection than the unmarried, which is really, really an interesting finding, and I think that there's a lot of room for further study and work to be done in that respect. But I also just want to highlight the importance of calling out girls who are under 18, adolescent mothers, as being children and girls. And I know some countries, they think of at 15 you're a woman, but according to the Convention of the Rights of a Child, if you're under 18, you are a child, you are a girl, and you have the rights of a child. And I just actually wanted to ask you, Layla, you were referring to young women, and I was wondering if you were referring to adolescent girls or if that was like a little bit broader spectrum when you were discussing that.
So when I was giving the definitions, the way we look at it, we base our definitions globally at IPAS based on UN, and then the way that plays out in our different program countries is totally different. Youth can be up to 35. In countries where we work. So we look at adolescents 10 to 19, youth 15 to 24, and then young women is 10 to 24. It kind of encompasses those two. It is imperfect. I really think it's very important to think about children, about girls, child marriage. I think it's very important to use that category because that's what they are. They're children. And so I think we tend to use different languages, and you're right. I think we need to think politically and strategically, and also represent who we're actually talking about. And so when I'm talking about a 10-year-old, that is a child for me. My daughter's 10, so I think of her as a child, and we use adolescent for that. But thank you. I think paying particular attention to the language we use and recognizing that is very important.
Yeah, and particularly when the definition tends to be more widely going up to 30, for example, that's when particular attention must be paid to adolescent girls, because what we see is it's older males that tend to be the service beneficiaries, and we lose the missing girls. They don't come and access the services, and so we really need to be particularly prudent that we intentionalize our efforts to seek out adolescent girls, and in particular when definitions are as broad to encompass the 30-year-olds, it's an impetus upon all of us to say, what about the 10 to 19-year-old girls? All of us. And unfortunately, now more and more we have to get younger and younger, and we're talking about where are the 7, 8, 9, 10-year-old girls, because we're seeing the pitfalls of early marriage, violence, HIV impacting girls at earlier and earlier ages.
Hi, I'm Linda Sussman from USAID. We've talked about HIV, and it was just mentioned before about the risk to adolescent, married, or unmarried girls, but also the impact of HIV/AIDS has meant that there's a large number of young people who are without adult care and protection. So either their mother or their father or both have died, and also there's a great deal of dependency and other impacts of the disease on the household level. And we hear anecdotally that has led to increased number of child marriages or increased risk of pregnancy among those children who are affected by HIV/AIDS. And I'm wondering if that's on the radar in the kinds of work that you're doing, not just HIV/AIDS, meaning these girls are at risk.
I think certainly, as I mentioned earlier, we work in Latin America, Africa, and Asia, and I think it's particularly important in the African countries where we're working. Anytime you're doing community work, mainly most of the networks and the groups that are organized are working on HIV, they're working on various sexual and reproductive rights issues, including HIV, and that comes up a lot. I think in terms of groups that are more vulnerable and lacking social support networks, which is what I believe you referred to, that's something, again, that I think we need to think about. What are the mechanisms to support those kinds of groups? What are the locations where they live, where they recreate, where they go, where we can reach out and support them? And what are the ways then, in a particular context, of reaching them most effectively?
Yeah, oh, sorry, go ahead. No, I was going to say, I think we often think when we think of OVCs, orphans and vulnerable children, again, we think of the under fives. And what we're seeing is orphans and vulnerable children are young girls as well, some of which were infected with HIV perinatally, some who acquired HIV through early sexual relations, etc. And they are sexual beings, as are male HIV positive young people as well, and really recognizing them as a cohort that has unique prevention, care, and treatment needs, prevention for positives, care and treatment needs, that we really need to ensure and tailor these services to meet them so that they can have healthy sexual relations, can have an HIV-free baby in the future, and can live, hopefully, normal lives.
Yeah, thank you very much for that. One of your response about being able to reach them in the communities, one of the difficulties that I've seen is that, for example, PEPFAR has separate funding for prevention on HIV/AIDS among adolescents and separate funding for children who are affected by AIDS, and so that prevents sometimes the providers for one are not necessarily the providers or linking adequately with the other. And I agree with you that, in fact, I don't know what the current statistics are, but under children affected by AIDS because they're orphaned by losing one or both parents, I know the old statistics, this isn't HIV positive children, but it's children who have just lost a parent. Approximately half of those were adolescents. And you're right that people think, oh, well, they're orphans, they're cute little kids that are on the Newsweek front cover kind of thing.
Was there one? Yeah, I thought so. There's a hand over there.
Thank you. My name is Nancy Termini. I work with the Population Council. I have a question that pertains specifically to post-abortion care, because abortion itself is such kind of a uniquely controversial issue in most of these countries. And Layla, you said specifically Latin America is kind of uniquely challenging with abortion being illegal. And I'm wondering, in what way do you navigate post-abortion care in Latin America when it is illegal, if you get into any barriers of providing post-abortion care, in the sense that the women who will receive post-abortion care presumably did something illegal? And if that is an issue, kind of how you do a cost-benefit analysis of working with healthcare providers in terms of what additional risk that would put the girls at?
Well, thank you for that question. I mean, it's obviously a very important one. So it's medically very difficult. You can't really determine a difference between a spontaneous and induced abortion unless often you can't. Let's just say that often you can't. There are cases where you can, but usually you can. And so part of it is ensuring that women are knowledgeable about what to say when they get to the health system to ensure that they're safe and that they can also present it as a spontaneous abortion if they so choose, which is often what they do. And even in the case of Latin America, where I mentioned that women are getting misoprostol through pharmacies in many countries, sometimes they're just getting the misoprostol to begin an abortion, and then they're going to the health system to complete that abortion. So they're starting their own abortion, and then they're going in for post-abortion care. So I think part of it is ensuring that you have networks of providers who are supportive, and we've done a lot of work around values clarification, around having dialogues with providers to ensure that they are providing services to women who come in with spontaneous abortions, and then also empowering and working with women to know what to say and how to navigate when they get to the service delivery site to make sure that they're safe. Because in some settings, what's happening is that you get to the service delivery site and a provider could call the police and call you in. And that does happen in some of the countries where we work. That's happened in Brazil. It's happened in different countries. So it's really thinking about what are the networks of supportive providers, and those people really do exist and they're out there, as well as ensuring that women know where to go, know where to get support and care that's women-centered and that's supportive of their choices. Does that answer your question?
Well, yes, please. Mm-hmm.
Hi, my name is Jamila Taylor, and I work for IPASS here in Washington. And my question was around the role of youth in community education, particularly comprehensive sexuality education. And I was wondering if Layla or Jen could speak more to what you're actually seeing on the ground in terms of the role of young people in empowering their own peers.
So we work with youth and peer educators in many countries. It's something that we're doing through universities in Ethiopia, where youth have peer networks and centers where they're educating individuals about sexual and reproductive rights, also educating them about the fact that the abortion law has been changed, that it's supportive of the rights of different groups of women. There's various legal indications for abortion. We're doing similar to work to that in Nepal. I think one thing that we're finding is that there's a lot of misinformation. And certainly, for example, if you go on the web, on the internet, something like abortion, if you Google abortion, it's all misinformation that comes out. So there's a real strategy to misinform on sexual and reproductive rights globally, on abortion specifically. That's what we do, so we know a lot about it. So it's really looking at how we can counter the ways that some youth are getting information. Not a lot of them don't, as you know, go to the web, but that's one area that we're focusing on, trying to make sure that people know where to get information that's medically accurate, that's reliable, and then to think about who are the messengers. Often the messenger is as important as the message. So who do people feel are reliable sources of information? What are the channels that you use to communicate information? So we use one-to-one, the interpersonal communication. We're also doing a pilot through SMS, so using cell phones to share information on misoprostol and medical abortion in South Africa. The hotlines, in some cases, women and young women prefer getting their information anonymously. So the hotlines and helplines have been a way of communicating both sex ed, educational information, and specific information about where to get services. So I think, again, it's context specific, and it's figuring out what do people already know, and what do they need to know to live lives that are safe and fulfilling.
Sure, and just quickly, the International Women's Health Coalition believes that working with young people is really the way that we're going to see real change occur, and in doing so, supporting youth leadership, youth mobilization, and youth empowerment, of course, are key central tenets of that, and we do that in many different ways. One of which is working with youth who are already working in country to realize change. One of my heroes in this world, as one example, is Ishita Chowdhury from the YP Foundation, who founded her own organization at the age of 17 and is leading the charge along with other youth-led organizations to essentially demand the right to comprehensive sexuality education in India. We have many other youth leaders that we work with and support their advancement of the policies within their own countries. We also look at discrete opportunities to foster their understanding of the issues through trainings. One is called an advocacy in practice, where we work with them so they can go and work in their own national countries and lobby their own governments, but also go to the UN and lobby for key documents such as the CPD, Adolescents and Youth document that will be negotiated in April. And so looking at opportunities to continue to build the movement and support the leadership of young people is really a key priority, and is one of the reasons why I co-chair the Youth Health and Rights Coalition along with Pathfinder International, work on the issues of child marriage, not only to raise the visibility of the importance of youth leadership and youth involvement, but also to provide key strategies to do that. So really, I mean, it's really at the core of everything we do, and is certainly what we see as the beacon of light in sometimes dark times of our world.
Well, as was suggested up front in terms of the erudite audience, that's become clear with the quality and breadth and depth of your questions, but also very adeptly handled by our two speakers and experts here. I want to thank them, and I want to thank you for joining in this important discussion, and hope that you will avail yourselves of continued conversations on these and related themes that are going on here at the center. So please join me in thanking our guests for today's session.